Over 80% of people say it's important to let their dying wishes be known, but less than 25% actually do it. Tonight on The Best Times, we discuss ways of preparing for the end. And we'll discuss the epidemic of prescription drug abuse among seniors. Funding for The Best Times is provided by the Plow Foundation, striving to do the greatest good by helping the greatest number of people since 1964. Additional funding is provided by the members of WKNO. Thank you. Hello, I'm Chris Hardaway. Welcome to this edition of The Best Times, a series that looks at life after 50. The phrase, end of life, is an uncomfortable one. We don't want to talk about dying, certainly not our own death or the death of a loved one. And the thought of putting a loved one in hospice or palliative care is tantamount to a death sentence. 60% of people say that making sure their family is not burdened by tough end-of-life decisions is extremely important. Yet 56% of us have not communicated our end-of-life wishes, either verbally or in written form. Tonight on The Best Times, we bring together a panel of 4 experts to discuss what we don't discuss: preparing for the end. I recently had a hospice experience with my father, and for about 2.5 months he was in home hospice. And it was an education for me, I have to say. I was not aware of exactly what hospice was and what happened. So maybe the first thing we should talk about is just simply define terms. What is hospice?
Mm-hmm. Hospice deals with people that usually have a terminal illness, and it's usually the last 6 months of life or less. So hospice can be done in the home, it can be done in a hospital, it can be done in a nursing home, and there are some places that actually have an inpatient hospice facility specifically for hospice patients, and we have that here in Memphis at Baptist Reynolds Hospice House.
Well, given the fact that it is, in the case of a terminal illness, mm-hmm. What's the goal of hospice? What are you trying to do in hospice?
Our goal is to make sure that the patient is comfortable, to support the family, to support the patient, and just give them the best quality of life that they can have.
So comfort is number one. Is that the difference then between hospice and hospital? Perhaps tell me what the difference is between the two.
That's a good question. The hospital is aimed at curing the illness, curing the reason the patient came in and fixing everything, where hospice is aimed at relief of symptoms. Hospice is not there to cure a terminal diagnosis, a terminal illness. Hospice is there to make sure that patient's pain, anxiety, nausea, shortness of breath, that those symptoms are controlled. Hospice doesn't lengthen life. It also doesn't shorten life. Hospice is just there to improve the quality of life.
Well, you bring up a good point there in the last statement you made, because I think some people think of hospice as a death sentence. Right. You know, you're going into hospice to die, but that's not necessarily true, is it?
People think it's you enter hospice and then you quickly die, and that's not the case. People on hospice are living until they die, and there's a big distinction there. They are living the best life, the best quality of life they can. Yes, you have to have a terminal diagnosis to be admitted to hospice, but it's about living life to the fullest.
And it's not only for the patient, but it's also for the family or the caregiver or whoever's deemed to help take care of that patient. I was about to mention that. What about the role that hospice plays in the caregivers, in the family? So we help that family start to deal with those issues. And the sooner that patient's in hospice along their terminal diagnosis, the more help we're able to provide that family.
Now, I've heard the term palliative care.
Yeah.
Now, is there a difference, or what is the difference between hospice and palliative care?
There is a difference. all hospice is palliative care, but not all palliative care is hospice.
Okay, straighten that out for me.
Yeah, so palliative care deals with a serious illness that you may be trying to cure. Patients on palliative care can also be in home care services, not hospice, and you're trying to get that patient better and get them to a certain trajectory in their life to make them feel better. Where in hospice, you're not on that curative road anymore.
How do you know when hospice is necessary, when it's called for? Is this something that the doctor prescribes?
It is. It's when that doctor has the conversation of there's not any more cure for this. And sometimes the families are the ones that realize that. And we may get a call from a family that says, hey, tell us about hospice and what you can do for us. And then we reach out to the physician to see if we can get that order to have hospice come in and help that family and that patient.
Let's talk a bit about medical technology, because medical technology has certainly changed, in a sense, changed the ways that we die. In doing research on this segment, I came across an interesting statistic, and it said that 40 to 50 years ago, most Americans died suddenly, accident, heart attack, stroke, etc. But today, more and more Americans are dying slowly. They quoted 90 million Americans with at least one chronic illness. So certainly medical technology is changing the way we die. Is that a good thing or a bad thing?
I think it depends on the person and what they want for their life. But the patient and the family have to decide at some point regarding that quality versus quantity of life, and is the quality and the symptom control piece more important than the amount of time that's left, but I'm dealing with all of this bad stuff.
In that sense, it puts more pressure on family and friends and caregivers even, right?
Yes, it does.
I mean, I'm thinking of, the famous case from years ago of Karen Ann Quinlan and her situation, which really opened up this whole end-of-life debate. But now families have to have that debate internally. I'm sure you've seen this firsthand. What do families do in those situations? Who do they look to? Who do they draw on?
This is the perfect time to fill out an advance directive then. If really all families should have that conversation.
Tell me what an advance directive is.
An advance directive is where you sit down with your families, with your close friends, husbands, spouses, and you discuss your plans, your medical plans, what you want in the case of a serious illness or as you get closer to death. I mean, it's not the most exciting and fun conversation to have, but it's a necessary one, and we all need to do it regardless of your age.
You make a good point about not having the conversation, because that is one of the issues. People don't talk about it.
Sure.
I think I read a statistic, 80% of people think that they should have plans, and only about 25% actually do. They haven't taken the time to fill out that form. Why is it so hard for us to talk about these issues?
Because we live in the here and now, and people, it's that let's put it off till tomorrow. And sometimes tomorrow doesn't happen. And so when that tomorrow doesn't happen and the crisis comes up, then if people don't know what you want and you're the person that's in the crisis and you can't speak for yourself, then you may have 3 or 4 other people trying to make those decisions, and they don't really know what decisions to make. Yeah. And when they're in crisis about their loved one, then that even heightens it even more.
Now, with an advance directive, what sort of questions are being asked?
Well,
how detailed is it?
Certain advance directives ask for you to name a healthcare proxy, and that proxy supposedly is the person you've had the conversation with and will make those decisions, like Rod said, when you're unable to. So that's one of the first things, is to maybe name someone who knows your wishes. And then it can go into more detail. If you are in a terrible wreck and you are on life support, it can detail what your wishes are according to that as well.
You mentioned healthcare proxy. Is that the same thing as a healthcare power of attorney?
Healthcare agent is the new word, I think, yeah.
Which is a second document that you really need to have. Correct?
Yeah, the living will is what Linda was describing as those wishes that you want to be known, and then whoever your agent is to help with those decisions if you can't speak for yourself.
When should we fill out these documents?
When you're not in crisis is the answer to that,
Well,
right?
That's the right answer, exactly.
Anytime there's a serious illness, talk about it with your aging parents. And really everyone who's an adult should have that conversation with their spouse or with their best friend, because not everyone gets to live to old age to make those decisions.
True.
It's not fun to talk about, but it puts a really hard burden on a loved one to try to figure out, what did they want? I have no idea. Often I will ask when they're making decisions, what has he said? What has she said that they would want in a situation like this? You know, we never talked about it. And that would be such a burden to have to make that decision. It makes it so much easier for your family.
You know, I was thinking it is hard for us to have that conversation with loved ones. Is it hard for doctors and medical professionals to have that same kind of conversation?
Definitely.
I think it's more difficult almost.
It is, and I think it also depends on the relationship that physician has with that patient or family. If it's a long-term patient that they've had, I think it's even harder for them to have that conversation, because physicians may feel as if they're giving up on that piece and not curing anymore, but they're just moving along to the next stage that's going to come about.
Exactly.
So I think that's where it plays a role.
Do you think the medical community is changing the way they treat end-of-life issues? And in what way, if they are changing?
I think that they are. I think there's more education in medical school now about hospice, about palliative care. Also, with some of my work in our inpatient unit at the hospital, I see more of a shift in focus of having those conversations with families. Is this something they would want? Maybe these attempts at what we're doing are futile. Sitting down and having conversations with families, with patients, and really looking where 25 years ago everyone was treated till the end no matter what, and those discussions weren't really had. They were on ventilators, they were tied to beds, and no one really had those conversations at all. So I have seen that climate change a little bit. And I think our new group of physicians are just going to be more educated.
And the other piece that falls into this is you're seeing more and more hospital systems bring in what they're calling palliative care services. And so where it's not hospice services, but palliative care and dealing with situations that are going on in the hospitals, but then those physicians and those staff in that area start having these conversations about what do you want and where do you see this going. And so that's another way that I think more education regarding end-of-life issues are coming about and helping us with that.
I think a lot of times the internists, the ones who work with these very sick patients, are having to make that call when to talk to the family, and they're learning, a lot of times I think they know when it's time, and they're learning better when to refer to the palliative care team.
Well, closing out, I just want to go around to each of you and give us your best advice.
So one thing that we have heard through the years in the home program is, I wish we'd have done this sooner. Mm-hmm. So that would be my hope. I think that's been an age-old problem in hospices everywhere, are late referrals because of lack of education, myths about hospice, maybe just lack of time for healthcare providers to talk to families. So going forward, I would love for anyone with a terminal illness who is not getting better, who doesn't want treatment, or the treatment's just not working, to be able to have those conversations with their doctor, to fill out their advance directives, and make sure that their family knows. We don't know how long the last chapter of their life is going to be, but it will be a lot smoother if it's planned out. And the beauty of what we do is getting to see a patient have a say at the end of life, to die where they want to die. If they don't want to be in the hospital, they can be at home, to have things done their way and have some control over the situation. So I would say start the conversation early and do it your way.
And you?
That's wonderful. As a volunteer coordinator, I guess my big push would be for the public, really, to not only do what Julie said and have your conversation, but to come and volunteer at hospice. We've got so many opportunities for so many different people, whether you just want to make phone calls for our bereavement program or checking in with patients. You want to sit and visit with patients, administrative work. There's so many different opportunities, and so I guess my thought would be, you know, if you want to give back to your community and to others, this is a wonderful and powerful way to do it.
And Rod, your best advice?
Yeah, so the first thing I thought of was what Julie said, is to have those conversations early. But the other thing is, don't be scared. It's hard, but don't be scared. And if you have questions about it, seek somebody to talk to it about. Somebody that's been through it before. Call us as hospice professionals. We're happy to come out and just talk. And we can help you through those conversations. Or talk to your physician about it. If they won't bring it up, you bring it up.
Well, I thank all of you for being on The Best Times and talking about preparing for the end.
Great.
Thanks,
Chris.
Thank you, Chris.
For more information about hospice and to download state-approved advance directive forms, go to the website of the National Hospice and Palliative Care Organization. When you hear the term drug abuse, you probably don't think about the senior population. But the National Institute on Drug Abuse calls the misuse of prescription drugs by older citizens an emerging epidemic. Current data shows that hospitalization among Tennesseans 65 and over due to painkillers has tripled in the last decade. Data from a 2012 survey by the Substance Abuse and Mental Health Services Administration estimates that over 330,000 seniors are abusing or misusing prescription drugs. That total should come as no surprise when you consider that the average person over age 65 takes 7 different medications per day. Let's examine the emerging epidemic of prescription drug abuse. Dr. Hill, define for me the difference between prescription drug abuse and misuse.
First of all, abuse means that you develop some kind of impairment from the way that you're using the drug. It may be that you're overtaking the drug or you're taking it at the wrong time, and that can lead to something that impairs your ability to do something socially or professionally, or even is doing something that hurts your health. So that's the definition of abuse. Misuse is a little milder of a term, which means that you're using a drug that it's not for its intended purposes. Or maybe you're even sharing a drug with another person that's not prescribed for.
Are there certain drugs that are more prone to being abused or misused?
I believe that medicines that have a mood-altering effect are a lot more likely to be abused or overtaken. And also medicines that are designed for pain, anxiety, and sleep have much more abuse potential than drugs that don't have a positive or a mood-altering effect on the brain.
In my research, I've seen statistics as high as 17% of seniors abuse prescription drugs, which is a pretty high number. What role does polypharmacy play in this problem? First of all, define polypharmacy for me, and then tell me what role it might play.
In the geriatric world, we define polypharmacy as taking greater than 5 medications. That may be prescription medicine and maybe over-the-counter medicine, but it's greater than 5 medicines. That would exclude things like hormones or insulin, things that are a replacement for a hormone deficiency that we might have for thyroid. So the definition of polypharmacy is you're taking greater than 5 medicines. The role that polypharmacy plays in abuse and misuse is really that the patient has multiple different prescriptions that they have access to, and they're choosing to either take something or not take something, choosing to take the correct dose in the correct way or take a different dose.
Let's talk about de-prescribing and what the medical community is doing in that regard?
Many medicines that we choose to stop or de-prescribe need to be tapered slowly because of the risk of what you would call withdrawal or what you might call rebound or discontinuation syndrome. The efforts to de-prescribe can save a community and an individual person a lot of time and a lot of money. And the medical community, even though we've all done a really great job identifying patients that need treatment, patients that need prevention, and people that need intermittent treatment, sometimes patients have collected many different medicines that may not any longer be needed.
Talk about the Beers criteria, which is, as I understand it, a relatively new set of rules or criteria for prescribing medication.
The Beers criteria was a list of drugs that should be used with caution in older adults. This isn't a list of drugs that are contraindicated, which means not to be given in the elderly, but these are a list of drugs that need to be used with extreme caution. There's about 100 drugs that are on the list. The Beers to make the Beers criteria, it really has to do with the side effect profile of a drug, that it might make your senses dulled, it could make you cognitively impaired, it could make your bladder have problems with the control of that, could make your balance poor and make you prone to falling. Working with seniors like I do every day, I usually find patients on 1 or 2 drugs that are on the Beers list and want to be sure that they're taking the smallest effective dose, or maybe I can make a safer choice for the patient.
Now, many older adults have multiple doctors. They may use multiple pharmacies. What role does this play in drug abuse and misuse?
It has to do with one medical provider, physician, not knowing exactly the medicine and the dose that another prescriber, physician is giving. Patients have the ability to use more than one pharmacy for different kinds of products, whether they're over-the-counter or whether they're prescription drugs. And so our lack of coordination in our medical system for seniors contributes a lot to this problem.
Well, let's talk about the signs, because what are the signs that doctors and nurses in the medical community can identify, or family members or caregivers? What are the signs in an individual that there may be drug abuse or misuse?
Just like any other drug that it goes to the brain, you may be seeing signs that the senior is unstable on their feet, that their speech may be slurred, they may have had a change in their personality or a change in their mood or a change in their alertness. And that would be seen by the family, that they're not taking such a good care of their appearance, that they're not meeting their obligations, their house is poorly kept, foods that are normally discarded after they're spoiled haven't been thrown out. And there might even be a concern that the patient is developing some kind of cognitive disorder, when really what's happened is that they are having medication problems.
It's interesting that you mentioned that, because as you went through that list, I kept thinking those are the same signs or indications of, in a mental issue. So it's interesting. What if you're a family member or a caregiver and you see these signs, what should you do?
Well, out of respect for the senior, I would definitely have that person speak to the senior about their awareness of their impairment. And ask them for permission if you can contact their nurse or their physician's office. Relay the information and the observations that you're making. I mean, I think it's all of our responsibilities to be sure that our seniors are safe and well cared for. And sometimes that means doing something that's uncomfortable, like contacting their medical doctor's office or contacting one of their children that may be involved in the care of the patient.
Well, Well, Dr. Hill, thank you very much for being on The Best Times to talk about prescription drug abuse among seniors.
Thank you.
For more information about prescription drug abuse and misuse, search the website of the National Institute on Drug Abuse. Want more information about life after 50? Go online to watch more shows and find more resources. And send us your feedback and story ideas to besttimes@wkno.org. That's all for this edition of The Best Times. Please join us next week for more stories about life after 50. Until then, I'm Chris Hardaway. Thanks for watching. Good night. Funding for The Best Times is provided by the Plow Foundation, striving to do the greatest good by helping the greatest number of people since 1964. Additional funding is provided by the members of WKNO. Thank you.